As a first-year resident, you'll undoubtedly be called into the emergency department to evaluate patients with sudden visual loss, and you will be asked to make a diagnosis of a central retinal artery occlusion or not. If there is a central retinal artery occlusion, there will be a combined care of the patient with the stroke team. So it'll be important to know the clinical aspects and the physical aspects of these patients. There are a number of styles of retinal artery occlusions, and these would include central retinal artery occlusions, branch retinal artery occlusions, ciliary retinal artery occlusions, or you can have a combined artery and vein occlusion. In this session, we will only be talking about central retinal artery occlusions. Central retinal artery occlusions are real, true ocular emergencies. First, timely treatment is important because you can not only save vision, but you may also be able to prevent strokes. And so you need to alert the neurology team, the stroke team, and maybe the cardiovascular team, depending on your situation. Also, it is imperative that you rule out giant cell arteritis. There have been times where a patient comes in with blindness in one eye, and with a delay of diagnosis and treatment, they've gone blind in the second eye. So you do want to make sure they do not have giant cell arteritis, and if they do, you want to get treatment started ASAP. The clinical features of a central retinal artery occlusion will be a sudden, painless loss of vision. The patient may have had an antecedent episodes of amaurosis fugax, but the main one will be the patient will be coming in with a sudden, fairly profound loss of vision. In fact, about 90% of patients with central retinal artery occlusions will have vision of count fingers or less. You should find an afferent pupillary defect, and clinically, when you look in, you will find a cherry red spot in about 90% of the patients. About 25% of patients may have a patent ciliary retinal artery. Visible emboli, only 20 to 40%. The vast majority will not have an emboli or any emboli visible. If you don't see a cherry red spot, you should be looking for whitening of the inner layer of the retina, and you can find this in greater than 58%. And now we'll show some clinical examples. The prior slide was a nice typical look to an acute central retinal artery occlusion. Now, you'll come across central artery occlusions in a number of different situations. There will be the acute occlusion, which will be symptoms of less than 8 hours. You may find this in your office or in the emergency department. Usually, however, you'll find that they are subacute and the patients have had vision loss greater than 8 hours to several days. And then finally, patients will come in who've had an undiagnosed central artery occlusion. You look at these patients, you can see that they now have some optic atrophy. That is a topic for another discussion. For the acute occlusions that you see in the emergency department, you do need to notify the stroke team and they will get the workup started immediately. You do, however, have some things that you need to do as that process is starting. If you do see someone in the subacute, there's not such a critical emergency, and that's another set of follow-up patterns, and we'll get to that very shortly. If you are in an emergency room, either with an acute or subacute central retinal artery occlusion, you do need to start some laboratory studies immediately because you need to rule out giant cell arteritis, and you need to do it right then and there. First, you'll be ordering a CBC. You need to rule out anemia, leukemia, polycythemia, and you want to look at the platelet count. Then you get a stat sedimentation rate, and the value that you're looking for is the patient's age divided by 2 if it is a male patient, or if it's a female patient, her age plus 10 divided by 2. Usually the sedimentation rate is about 70, but there can be times that maybe it's 35 or 40, so you have to be very careful on those patients. And then you need to look at a C-reactive protein, and in one of Dr. Hayray's articles, he found that a level of greater than 2.54 was fairly indicative of someone with a giant cell arteritis. So if this is an acute patient, so while you're waiting for the stroke team to come down and arrange for all the testing, the one thing you want to do is to reduce the intraocular pressure as quickly as you can. The two time-honored ways of doing that would be either digital massage. Put your thumb on the eye for about 5 to 10 seconds and then suddenly release it, and repeat this 5 or 6 times. What you may be able to do if you're lucky is to dislodge an embolus and have it travel farther down the arterial path, so there's a smaller area of damage from this occlusion. Another very good way of helping a patient, and even for me this has been helpful several times, is to do an anterior chamber paracentesis. Obviously you want to numb the eye, then put some betadine in, put a 30 gauge needle into the anterior chamber, and acutely lower the pressure. It's difficult to get it lower than that because you'll get it down to 0, and that'll be the best way of trying to dislodge an embolus if that is possible. And you'd want to do that as the stroke team is being called, or if that is in your office, you want to do that prior to sending them to the emergency department or having the ambulance pick them up. If it is a subacute and the occlusion has been there for more than a day or two, then don't bother with that, because you're just putting the patient at risk, and the damage is done. You're not going to make that much of a difference. Your other job is to make sure that you follow up on these patients, because 18% will get rubiosis, neovascularization of the iris. That is not good. Now, on these patients, that can occur on an average of 4 to 5 weeks after the occlusion, as opposed to 3 to 5 months after the vein occlusion. There is one article that states that if you do an angiogram a week later and the artery is open, there's a lower risk of getting rubiosis, and if the artery is still closed long term, that is when they have a higher risk. So you may want to watch these people weekly for the first month, and then bi-weekly for about a month or 2, and that will be your responsibility on the intermediate care of this patient. Here's a color photograph and a red-free photograph of a patient who had had a sudden vision loss several days prior to the presentation to the eye clinic. The photograph on the left, you can see some very intense edema, mainly in the papillomacular bundle, but it does surround the fovea, giving a reddish look. The fovea is red because you can still see the RPE in the fovea. The fovea is supplied by the choroidal circulation, not the retinal circulation, so it will not become edematous, and it is thinner than the rest of the retina, so you can see the RPE. However, the retina surrounding the fovea does have all the elements of the inner nuclear layer, the outer nuclear layer, and the plexiform layers, and the ganglion cell layer and the inner nuclear layer are edematous, and that gives the whitish appearance and thus the cherry red spot. And here's a fluorescein angiogram of that patient. The upper left photograph is in the choroidal phase, and you can just see the filling of the central artery on the nerve, but none of the other retinal vessels are filled. The upper right-hand photograph is several seconds later. You can see the arteries are barely filling, but otherwise the arteries are not filling and the veins are not filling. About a minute into the angiogram, the lower left angiogram shows that the arteries are filled. However, the blood flow is so slow the veins are not filled and the retinal capillary bed of the retina are not filled. Late, about 2 to 3 minutes in the angiogram, is shown in the bottom right photograph. You can still see some filling and slow filling of the central retinal artery. The superior veins have not totally filled, and there's a very dark hypofluorescent area in the macula, more than just the foveal avascular zone, and this is because the inferior macular artery still is not filling, and that is why the capillary bed in this area is not filling, and that is why it is still hypofluorescent. This gentleman has a different pattern. You can see very intense retinal whitening in the superior and inferior macula and a very good cherry red spot. However, if you look in the papillomacular bundle, it is quite red. It is red because there is still blood flow present in this area, and that is a reddish area of normality in the sea of white retinal edema. The retinal vasculature here is still present because this patient has a cilioretinal artery, and the arrow points to that. And the cilioretinal artery, if you remember, is fed by the choroidal circulation. So that is why you see this particular pattern. If you do see a patient early on, there may not be a lot of retinal edema. That may take either hours or a day or so to develop the full-blown pattern. Here is a 61-year-old with 1 day of blurred vision, and we took the photograph on the left at the initial visit. You can see a mild whitening in the inferior macula and the superior. There's maybe a subtle hint that there's a cherry red spot, but the superior and supratemporal macula is still not too edematous. 1 week later, when the patient arrived, the vision was still at the 20/40 level because there is still some flow from that one arteriole that you can see going towards the fovea, but the edema is much more pronounced, and it's not just photographic. If you look supratemporal, beyond the one vein that comes down temporal to the fovea, you can see the edema is much more pronounced than it was on day 1. And the arrows do point to this particular area that I'm talking about. And this is one more example of a subtle finding. The nerve is slightly pale, which you can see in artery occlusions even early on. There's a very good cherry red spot. However, the retina in the superior and inferior macula are not as white as the prior case, but there it is white. And again, this patient has an intact cilioretinal artery, which is why you see that contrast centrally. Now we'll show you a fluorescein angiogram of this patient. Here is the fluorescein angiogram of the prior patient. It is early in the angiogram. However, you can see normal filling in the papillomacular bundle. This normal pattern is because this patient had 2 cilioretinal arteries, and therefore the capillary bed in the papillomacular bundle is filled. The central retinal artery is not filled. It's just partially filled at the 6 o'clock, and you can see the branch there, but nothing else is filled in the retinal arterial or venous circulation. Even though plaques are seen in only 20 to 40% of the patients, they are important for the prognosis and other systemic associations. There are 2 basic types of plaques, cholesterol and calcific. You can also get fibrin, but these are many times temporary, difficult to see. The cholesterol plaques are usually from the carotid arteries. They're small, so they don't totally occlude the arteriole. It is important to find them, and you need to look very closely because you do have to have a really good cardiac and cardiovascular and carotid workup. Calcific plaques are larger. They tend to be at the bifurcations, many times on the nerve, and they originate from the cardiac valves. So it is interesting, even though you do find plaques, there's a low prevalence of carotid atherosclerosis requiring carotid endarterectomy. And that's a quote out of Ryan's textbook. But there is a higher risk of mortality in the next 5 to 10 years. And this is from cardiovascular problems. So if you do find the plaques, you really need to get these folks to a cardiovascular surgeon or a cardiologist who takes care of this sort of a thing, because they may want to be put on anticoagulation long term to try to reduce this mortality. Here is an example of a cholesterol plaque. You can see it in the supratemporal arteriole right at the bifurcation. Even though it looks like it may be larger than the arteriole, it actually is an optical illusion. It is smaller than the arteriole, and it is smaller than a typical calcium plaque. This patient has a fairly noticeable plaque right at the bifurcation of the central retinal artery as it comes into the eye, and you can see this right in the middle of the optic nerve. This most likely will be calcium, and most likely coming from a cardiac valve. Patients with central retinal artery occlusions oftentimes do have systemic problems, and these would include hypertension, diabetes, cardiac valvular disease, or carotid stenosis or plaquing. A small percentage of people will have temporal arteritis. If the patient is over 55 years of age and you do see a central artery occlusion without a plaque, you must get an emergency CBC, sed-rate, and C-reactive protein. If the patient is under age 50, then that should be done automatically. If you do see a plaque, that one is not necessary, but all the full cardiovascular workup must be done. In summary, acute central retinal artery occlusions are a true ocular emergency. The first thing is you want to make the correct diagnosis. The second is you want to alert the stroke team or get the patient prepared to get into an ambulance to go to an emergency department if you do see them in the office, and alert the hospital that this patient is coming and what your diagnosis is. Now, while you're waiting for all that to be done, you want to lower the IOP as much as you can, and that could be by digital massage or an anterior chamber paracentesis. Of note, you do want at least a carotid ultrasound, if not a CTA or an MRA. There's no specific guidelines as to what one is better or which one you should do or which one to avoid. And then you also want to order a STAT CBC with differential, sedimentation rate, and a C-reactive protein. If these are positive and you think there may be temporal arteritis, you then would like to alert the ER team to start immediately IV methylprednisolone, and also get a general surgeon involved who can do a good temporal artery biopsy. The details of this will be on a talk on temporal arteritis. Vanderbilt does have a central retinal artery occlusion protocol. If it is hyperacute, that means there is vision loss less than 8 hours, and the best corrected visual acuity is less than 2200, and there's arteriolar narrowing in all 4 quadrants, or a cherry red spot, or a RAPD, then the stroke team is called automatically. There are times the patients will come in with a sudden vision loss. The stroke team has already been called, and you'll be called in to give the definitive diagnosis. Is this a central artery occlusion? And then the full protocol and admission for cardiovascular workup and stroke workup will begin. If you find another reason, such as a retinal detachment or a vein occlusion, then obviously you will call off the stroke team. But many times they will ask you to make the decision, is this an artery occlusion, is it not? But the stroke team itself will make the final decision as to whether to admit and start their stroke protocol.